Welcome to the November 2025 talk with the doc with Dr. Timothy Leichliter from Allegheny Health Network. He is a movement disorder specialist with Allegheny Health Network and offers his time each month to answer your questions. Thank you, Dr. Leichliter, and please take it away.
Thank you, Casey. Well, welcome back, everybody. I missed last month because I was driving, but now I'm back. So welcome back to the party. For those of you who don't know me, I'm Dr. Licklider, sitting here in my office at Allegheny General Hospital, looking at it not raining yet, but knowing what's coming down the road. We'll see how that goes. So this is a good question and answer session. So type in your questions into the chat box and I will answer them. My usual caveats are as follows. So this is a good general information session. So if you have questions that are general, that's great. If you have individualized questions, that's not so great. Those are all good questions to have with your doctor, your neurologist, your treating team. And then the other thing is everything you hear is my opinion. I have a lot of opinions. I have no problem sharing my opinions. I will tell you my opinions, but they are my opinions. If you go to somebody else, neurology, movement disorder specialist, they may have different opinions. I like to think that I give you the best opinion that I can come up with based on medical fact, but well, sometimes I have to make stuff up, and I do, and I will tell you when I'm making stuff up. But for the most part, I'm going to give you the best information I can come up with. And we're drinking chamomile today because I think I was having a little bit of a throat tickle. More to come on that. Let's just hope it's allergies. So I'll start with the ones that I got in my email. As soon as I can find my email here in a second, I was looking other stuff up. Not too many, but again, feel free to type them in the chat box and I will get to the chat box after I get to the email. So the first one was, please discuss restless leg syndrome. Why do some people with Parkinson's get it? What are some treatments for it? So restless legs is one of those odd entities that I also take care of. So restless legs can be a standalone condition. I have plenty of patients who just have restless legs who do not have Parkinson's disease or other neurological conditions. But I will say that a lot of my not a lot, some of my Parkinson's patients also have restless legs. And sometimes restless legs comes and then they develop Parkinson's disease. Any and all of those are what I hear of and see a lot of. We don't really understand what causes restless legs. There's a lot of theories out there. They're still working on trying to figure that out, but we really haven't gotten to the bottom of it yet. Restless legs, plain and simple, is exactly what it sounds like. It's really an irritation, uncomfortable feeling that makes you want to move your legs. And a lot of times people say, yep, I get this feeling in my legs. I have to get up and walk, and then I can try to sit down. A lot of times it happens at night, but sometimes it can be all day long. It doesn't just have to be legs either. It can be restless whole body if it gets bad enough. But it really is an uncomfortable feeling that's alleviated by movement, which unfortunately, if you're trying to go to sleep, getting up and moving is not exactly ideal for trying to go to sleep. Now, in Parkinson's disease, there's also a couple of other sleep problems. So, similar but a little bit different to restless legs is periodic limb movements of sleep. The difference is restless legs is a feeling you feel while you're awake. Periodic limb movements of sleep are really noted by the bed partner because you're asleep. But the idea is just these extra movements, usually in the legs, that are irritating. And then what I see in Parkinson's disease, probably even more common, is something called REM behavior sleep disorder, which is acting out dreams, nightmares, yelling, kicking, fighting, punching, throwing yourself out of bed. That's a little bit of a different sleep problem. When it comes to restless legs, it really is a subjective feeling by the patient themselves because they're awake. And again, it's that need to get up and move. And why we haven't, I feel like we haven't done a good job of figuring it out is there's a lot of things that are either used to treat it or intertwined. Probably first and foremost is iron. So we know that iron is somehow related in the pathology of restless legs. And we know that because in people whose iron stores are low, either their iron levels are low or their ferritin levels are low, which is the protein that carries iron places, then all the medicine in the world doesn't help restless legs. And there have been a couple of patients that I've been able to, I won't say cure, but at least significantly help, plain and simply by giving iron infusions to restore iron levels. And so if you come to me with restless legs, one of the first things I'm probably going to do is check an iron, a total iron binding capacity, and a ferritin level, because all of those are markers of iron deficiency. And it needs to be replaced if they're low, because realistically, it's very, very hard to treat restless legs if iron stores aren't fixed. But then the other thing that makes me believe that we don't really understand it is there's multiple different types of medicines used for restless legs. So the classic treatment would be the dopamine agonist. This would be ropinirole, which I don't think is very good, but primary care doctors like to use it. Pramipexole, which is Mirapex, is probably one of the top two drugs I have for restless legs. Now, the downside to this class of and Nupro patch also is approved for restless legs. Now, this class of medicine is very well known to cause problems like augmentation, which is you need more and more and more over time, and you become pseudo addicted to it. It also comes with impulse control problems, sleep attacks, things like that. So we try a lot of times to stay away from that class of medicine, although it does work very well. And interestingly enough, the gabapentinoids also tend to work for this, which have a very different mechanism of action of the dopamine agonist, which is why I don't think we quite understand the pathology behind it. So Horizont, which is a formulation of gabapentin, is probably the other best drug that I have for restless legs. Although in terms of that class of medicine, it's the hardest to get. Lyrica is probably second best, but also second hardest to get. And regular old gabapentin is probably the easiest to get, but probably also the least effective in my experience. But that class of medicine is probably where we would go first because they do help. Also, interestingly enough, other medicines, carbidopa, levodopa can sometimes be used. And interestingly, the opioids sometimes help too. And so the fact that all of these different classes of medicines tend to help restless legs really lead me to believe that we don't really have a good understanding of why or what happens. And that's kind of what we think about in terms of restless legs. So again, very common, very can be very disabling for people who it really disrupts sleep. Sometimes very difficult to treat, and I have had patients where a lot of the I need a lot of different medicines or combinations of things to really see if we can do better. But definitely worth discussing or bringing up at your doctor's appointment if you're experiencing it, because there are things we can look into. Even if it's just let's make sure your iron levels look okay and go from there. That's I think enough about restless legs. And I'm drinking chamomile. I think I mentioned that. What do I think about light therapy for depression and sleep issues? I mean, I think it's a reasonable option. And so I go back probably a few years now at the movement disorder meeting. We had a sleep specialist give us a talk about light box therapy, which is you buy one of those boxes that shines a light in your face. And there was actually pretty good evidence to suggest that it helped with both of those things. So depression and mood, but also sleepiness, and sleep issues associated with Parkinson's disease. I don't know that I'm not the expert on a light box by any means. There are definitely parameters for how much whatever the measurement of light is that I can't remember offhand. Um, in terms of how much you need to get the benefits, the sleep doctors are probably better at this than I am, but there is some actual evidence to suggest that it does help. And it's non-invasive. Again, it's a light box. Does take some time. Does take you buying the apparatus because I also don't think that's covered by insurance. But realistically, it's not another pill. It does help some people. Probably the best light box is the one that's out here, although in Pittsburgh we don't get a very good one. And so this is part of the reason I think people do better when they go down to Florida or Arizona for the winter, but that's just my opinion. Because I do think there is something to be said about light. We know light controls circadian rhythms in terms of sleep wake cycles. We know that mood is impacted by a whole bunch of things, not just sun, light, and vitamin D. And so at the end of the day, I do think there is some benefit to light therapy. I don't know that I've had too many people do it. Whether because they don't believe me, I'm not very good at talking about it. I'm not sure, but I have had a couple of people get a light box and they think it helps. I don't think it's the cure all, but I think in the end it does help some. And again, if you're interested in doing something that might help, that's not another pill, fairly is low risk, I think it's definitely something worth looking into. Please comment on prasinezumab as hopeful treatment for Parkinson's. I would love to because I'm actually going to be involved in the study coming up here next year. So prasinezumab is a Roche kind of research drug. I guess that's the best term for it. It basically targets misfolded alpha synuclein. And so it went through phase 1 and phase 2 trials, and the phase 2 trial actually failed. And what I'm learning in movement disorders is time and time again, we see drug trials fail, and then they go back and sort of select different parameters or specific classes of patients, and they can show trends towards benefit. I've seen this not only in Parkinson's disease trials, I've seen this in essential tremor trials, and then they move on in that subclassified kind of specific group of patients to a phase 3 trial. And that's exactly what they're doing. So I will actually be running that here in my office at Allegheny. It's an infusion trial. It's for early onset, early Parkinson's disease on very low amounts of medicine. So just in case you're wondering if you qualify for it, to really see if blocking misfolded alpha synuclein or altering alpha synuclein slows down disease progression. I mean, that's what we're aiming for. We've known about alpha-synuclein for a really long time. This is the protein that misfolds and clumps together and forms a Lewy body. The Lewy body is the pathology hallmark of both Parkinson's disease and Lewy body disease. And there's always been a question about whether or not alpha-synuclein misfolding is the cause of Parkinsonism or Parkinson's disease, or is just a byproduct of the disorder or the disease and just something that you can find when you look at pathology slides. And we really have not answered that question. Um, and that's what we're trying to answer. We're trying to see if we can actually target this misfolded protein, decrease its clumping, see if we can alter its course, and if that has any impact in disease progression. And so as the question says, hopeful. Now, if you've been to any of my talks, you know that my hopeful is low. Um, I wouldn't say I'm pessimistic, but I like to say I'm realistic. But I do not get my hopes up until I see actual good evidence in phase 3 trials. And so you guys are all more than welcome to be hopeful. That is your prerogative. My job is to be realistic and really temper my excitement until I see good data. And so while we're hopeful and theoretically maybe it looks promising, I will give you more information once we do this study and once we see the end result. But that's what we're looking at on this study drug called prasinezumab, where we're really trying to target alpha-synuclein. The next one was interesting because if you open up the article they sent me, you just see a picture of me, which always throws me off. I don't always like to see pictures of me pop up, but this was an article that I did, or they asked me to really review a study where they were looking at this virus that seemed to correlate with people with Parkinson's disease. And we also talked about the Parkinson's belt at that time. And so those are really two studies that I think came out of Chicago or Northwestern that they wanted my opinion on. That's what this was. And so on the one, they did pathology studies of people with Parkinson's disease, and they found a higher than likelihood of this human virus. Now, this virus is theoretically not known to cause any illness in humans. It is this quote unquote benign virus that we just find incidentally, and they just happen to find it more incidentally in people with Parkinson's disease than without. Now that is interesting, but again, and if you read how our commentary went, it's like, okay, that's interesting, but we need more information, right? Causation is not evidence, or correlation is not causation. That's definitely not enough evidence to say, yes, this is the problem. This is why people get Parkinson's disease. We need to attack this and target this, and that's going to fix the problem. It would be nice to say stuff like that, but I think that's a little bit premature. And so at the end of the day, it's an interesting thing to show that, okay, we have another thing we can look into and really test this theory and see if this has any relevance to it, or is it just an incidental finding? I always like to give the example because my neuropsychologist taught me this, and I thought it was very interesting, the difference between correlation and causation, because it's really important that you keep this in mind when you read stuff like this. So she always used the example of, when it rains, you see everybody with umbrellas up. And the correlation you can make is that, well, when it rains, people put their umbrellas up. The other correlation that you could make that would be incorrect would be that when people put their umbrellas up, it makes it rain. And so you have to keep that in mind when you're looking at stuff like this. Correlation is not causation. And that is something that I go over with patients a lot, because you read something like this and you're like, this is the problem. This is the culprit. But you have to take it with a grain of salt and actually look at it and do the appropriate research trials before we can get excited about stuff like this. Similarly, but a little bit different, was the other thing that we talked about in this article, which was about the Parkinson's belt. And there's a lot of talk about this these days. And the Parkinson's belt is basically these areas where there is a much higher incidence of Parkinson's disease than, say, typical. And Pittsburgh falls into it. So it's basically the Rust Belt that goes across Pennsylvania into Ohio, West Virginia. And then there's an area, I think, down in Texas, but over in California. And these were areas that seemingly Parkinson's disease happens more frequently. And they just so happen to correlate with areas of high industry, hence our area, toxic pollutants, things like that. Down in Texas, I think it was some other pollutant, and over in California, it was pesticides sprayed on golf courses, which you will also read about. And so the idea is that there's some environmental trigger or cause that is really leading to the uptick in people with Parkinson's disease. Again, another correlation. It is really hard to prove causation, although you will hear there is a lot of talk about this, not only in patient world, but in my world, in the movement disorder society, and now even pushing it up to government and legislature, although they don't seem to work. So I guess that doesn't really make a difference. But anyway, there's a lot of talk on that in terms of, pesticides and paraquat versus trichloroethylene and degreasers versus some of the pollutants from the steel mills that we had here, and how these things could have triggered or caused the underlying things in Parkinson's disease. And while I think there's still a ways to go to prove all of that, there is definitely enough kind of circumstantial evidence to suggest that we should at least be paying attention to it. I don't know what to do with that information. At the end of the day, it doesn't help me treat patients. It doesn't necessarily change anything that I do, but it hopefully is a step in the right direction to get to the underlying answer of what causes Parkinson's disease, or why do people get it. Because my personal opinion, and this is my personal opinion, although I feel like other people share my personal opinion on this one, is we are going to have a hard time fixing it, or slowing it down, or curing it, or preventing it until we really have a better understanding of why people get it. I think that really is the first step to coming up with a cure or a fix. I think if we can figure out either the genetic constituents or the environmental triggers or the combination of events that leads people down the road that ultimately ends in Parkinson's disease, I think that's a really important first step in saying, okay, now that we know what causes it and theoretically we can measure it, now we can actually target it with specific medicines or treatments or therapies and things like that, and we can see if we can slow it down or stop it. And so that's where I think that these are really interesting and important topics. They're not solved yet by any means. I don't think we have come nearly close to figuring out all the ins and outs and proving any of this stuff, but that's what a lot of researchers are doing right now. And so I think the more we talk about it, the more you hear about it, the more we research it, the closer we get to that answer, which in turn allows us to get closer to the fix. That's just my opinion. More to come on that. We'll see how that one goes. And then the last one that I got an email was a study about um, FGF1, which is fibroblast growth factor 1. That's a mouthful that I have trouble saying. Um, and I'll spare you the kind of excitement for it, but it's basically this Genesis medicine company that is trying to do this. Basically, what they're trying to do is regrow blood vessels, or angiogenesis is the other name you will hear. However, at the end of the day, if you look at the thing that I got sent with it, it says that they're looking to recruit or start doing a trial in the next 3 or 4 years. So that to me tells me if they're not looking to start for another 3 to 4 years in terms of recruiting for this, it's then going to take another couple of years after that to do the trial. It's then going to take another couple of years after that to get any type of approval. And so, I mean, I can look at stuff like this, but we're still talking years and years down the road. And so I'm not going to get excited about something that is still years away from even getting started, because I got a lot of nearer things to get a little bit excited about, I think. And so again, I'm interested in anything that helps regrow brain. Again, this is the same idea behind stem cells. Anything that helps regrow or reinnervate or regrow blood vessels, that might help blood flow to the brain. Again, these are all really good ideas, but we need better evidence. We need research trials that can actually prove this stuff. And so if we're still that far away from it, I'm not going to get excited yet. That's my opinion on that. You can get excited, but I'm not going to get excited just yet. And believe it or not, those were the only ones that I had in email. There actually weren't that many email questions. So I will jump to the box we got over here. Again, if you think of questions, keep typing them in. I'll start at the top and work my way to the bottom. I would like to start the medicine, levodopa, but I can't see my doctor until January. Well, it might be my patient. Welcome to my office. It's so hard to get into offices these days. I don't know if it's just my office or if that's a universal, but at the end of the day, it's just incredibly difficult. It's so very packed and busy. It is really hard to get appointments. I was told I could ask for a prescription before the appointment, but how will I know how to take the dose and what to watch for? If you're my patient, send me a message. So at the end of the day, us at Allegheny Health Network have my chart. UPMC has UPMC something. I don't know. I forget what theirs is called. But at the end of the day, these are modes of communication. And so send a message. I mean, if you're my patient, I would say, this is how I'm going to start it. This is what I'm looking for, and this is to watch out for. We all have different ways of starting levodopa. I have my own philosophy, but I'm not going to tell it to you because if you don't see me, you might get something different and then be like, wait a second, Dr. Lickletter said we got to do this, and that's not true. There's a bunch of different ways you can start somebody on medication. I just have my own personal preference. And what we're looking for is success, right? We're looking for less stiff, less shaky, less slow, easier to get up and move. Probably biggest, this is for everybody, probably biggest side effect is upset stomach. That's about 10% of people have significant nausea with it. It does work best on an empty stomach, but at the end of the day, if it makes you sick to your stomach, I'd suggest starting it with food, and then transitioning to an empty stomach once you tolerate it. Yes, at higher doses or the longer you're on it, we worry about hallucinations and dyskinesias and motor fluctuations. But when I start somebody on medicine, I don't worry too much about those unless you're already having them. And really, it says I say just kind of start it and let's see how it goes. If it works, great. If it doesn't, it can be adjusted. That's kind of the long and short of it. But the short answer to your question is send a message to your doctor, say, hey, you know what, my symptoms are bothering me. I really want to try something. Let's get this started. That way I can report back to you in January when I see you how it's going. And they should be able to tell you how to start it, what to look for, and go from there. Do you ever prescribe medication for Parkinson's patients that are depressed? Do you ever recommend medication for Parkinson's patients' caregivers that exhibit symptoms of anxiety or depression? Yes, and sort of, or no. So I treat my patients for depression not infrequently. Now, I will throw out the caution. I am not a psychiatrist. And nobody likes it when I say, hey, you should really go see a psychiatrist. Because the first answer I get is, well, I don't need to see a psychiatrist. They're not going to help me. I'm not crazy, blah, 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 blah. Fake news, but I hear it all the time. Psychiatrists specialize in anxiety and depression, as well as a whole bunch of other stuff, but that is their area of expertise. And so even though I can prescribe antidepressants and primary care doctors can prescribe antidepressants and anti-anxiety medicines, we are not nearly as good as psychiatrists. And so realistically, if it were up to me, I would utilize psychiatry so much more than I do. Now, part of that is because patients don't want to go. And part of it is because psychiatrists are actually really, really hard to find. In fact, they're even harder to find than me. And so it does become a challenge. And so by default, I do end up treating patients for depression, if need be, and I can use antidepressants as well as the next person. It really gets to when the antidepressants aren't working, or we're needing to ramp it up, or we're needing to add combinations of things. That's when you really need a psychiatrist or somebody who does this better than I do. And I would argue the same thing is true for your primary care doctor. Primary care doctors can also deal with anxiety and depression to an extent. I'm sure they're comfortable using SSRIs or SNRIs or different types of classes of medicines to treat these disorders. But when you have refractory problems or things that aren't responding very well to medicines, or we're needing combinations of things, you really want to go beyond what a PCP or even myself can do, and you really want to get to somebody who specializes in this, which is a psychiatrist. It is not a character flaw. It is a part of Parkinson's disease. Statistically, 40 to 30 to 50% of patients with Parkinson's disease have apathy, anxiety, and depression. That is a severe underestimate. I would argue that if not everybody, nearly every single person that I see with Parkinson's disease at some point in time has signs and symptoms that would qualify them for anxiety and depression. It is that common, and it is indeed a part of the underlying disease. However, that does not mean that I am the best person to take care of it. Just like urology problems and GI problems and sometimes sleep problems, these are all underlying parts of Parkinson's disease, and I can treat them to some extent. I am not the best person to do it. A urologist, a gastroenterologist, a sleep specialist would be more beneficial. And so psychiatry is the same way. Yes, it is a part of the underlying Parkinson's disease, but psychiatry does it better than I do. I can do some, and I'm confident doing some, but there are some patients that get to the point where you need more help. The second part is a little bit questionable. So I don't know that I've definitely never treated a caregiver of a patient of mine. You really have to be a patient of mine for me to treat you with medications. I have suggested to caregivers that they get evaluated or treated either through their primary care doctor or a psychiatrist or a therapist or things like that. Because believe it or not, anxiety, depression, apathy not only affects people with Parkinson's disease, but it also carries over to caregivers quite frequently. And the impact on quality of life is not just for the patient, it is indeed for the entire team. And so I have suggested it to caregivers, although I myself have not treated or given medications or recommendations specifically to the caregiver, if that makes sense. It's a great question, and I think at the end of the day, both need to be considered, and everybody on this call should really keep these things in mind, um, because they really are big parts of the disease. And we know for a fact that if these go unrecognized or untreated, everything gets worse. Patients do significantly worse if the mood problems are not addressed. That is a fact. And so do not hide these things, bring them up, discuss them with whoever's taking care of you, and do not be afraid, shocked, or angry if they then say you should see a psychiatrist or a psychologist. That is part of the treatment team. Do I know anything about Rustral EMS foot activation to help with freezing? No. But that doesn't mean I can't type it into my computer here and see what it is. So this looks like either, let me open it up here. So it looks like it either vibrates or electrically stims, both of which I have heard about. It looks like that maybe this is an electrical stimulation. Basically, it's a mat or a device that you stand on or set your feet on, and there are some that vibrate. Vibration plates I'm often asked about in terms of balance and walking and things like that. And there's a little bit of evidence there, but it's not great. Same thing is true for the electrical stimulation, both in terms of neuropathy, but also in terms of walking and balance. Um, I don't know that I've ever seen a study specifically aimed at freezing of gait, which is a very hard thing to treat from a just medication standpoint in general. But I have seen data on walking in general and balance. And again, the data is okay. I mean, it's not great. Believe me, they're not going to do randomized controlled trials for stuff like this. It would cost far too much money. And so to get actual good evidence for stuff like this is going to be probably impossible, or never going to happen. I think there is enough science that I've read about in terms of these different stimulation patterns or techniques for the feet to see if it helps, that there is some scientific rationale to these being beneficial. I think they're fairly low risk. I don't think, I mean, I'd have to look it up, but I don't know of any major side effects that you can get from this kind of thing, although you do have to always look it up. And so my opinion would be is that even though I couldn't recommend it necessarily, I wouldn't be against it if you tried it, as long as it's cost effective. So when I'm dealing with devices like this or anything that over the counter or supplements or vitamins or basically things that I know we're never going to get gold standard evidence, it really comes down to three things if I'm okay with it. One, there has to be some sort of scientific rationale, and I think there is. There's enough proprioception in your feet and signals that can go up that could relay some of this to help with walking and balance. It has to be non-toxic, and I don't think there's a large risk to this, although again, that I would have to look up, and it has to be relatively cost effective. I don't want anybody getting into the poorhouse because they're buying stuff like this, devices, over-the-counter supplements, things like that. But as long as those three things are fulfilled and you want to try it, I'm all for it. I don't know that anybody specifically has come back and told me about this one, but if you try it, let me know how it goes, and I'd be happy to share the word. Amazon has the Okay, the seasonal affective disorder lights, but yes, research for use. Okay, yes, there is some evidence for them. But again, you just have to figure out which ones have the correct light ability. I don't know what the right there is a word for it. I just don't know what it is. What do I know about the honey trick for Alzheimer's disease? I don't know. I'm learning all kinds of stuff today. Let me take a look at that one here. Actually, somebody just asked me about honey today and pollen today, and I thought that was interesting because there's a lot actually looked at bees for it. And I guess this is for Alzheimer's disease, but there's actually been some look at this in Parkinson's disease and the neurodegenerative disorders in general. So in terms of bees, they've actually looked at bee sting therapy. There was actually a couple of papers written about that in terms of how bees sting, which I don't know why you would want to do that personally, but hey, if it worked, I guess people would do it. But it actually had some evidence to actually be beneficial in Parkinson's disease, although it was weak data. I wouldn't go overboard on that. But then there has been looked at pollen and honey therapy in terms of the neurodegenerative condition. So honey's been around for thousands of years. Its use in medicine has been used for thousands of years, both in terms of antibacterial kind of wound treatment, things like that. We know it has anti-inflammatory properties, antioxidant effects, and when you start thinking about those words, other things come to mind: turmeric, CoQ10, glutathione. Right? These are all the things that have been looked at in Parkinson's disease because we know that oxidative stress, inflammation, effect on the mitochondria play a role some way, shape, or form in Parkinson's disease or the development of Parkinson's disease. And so when you start thinking about these different effects that honey could also have, you can see where it's probably useful in the neurodegenerative world. I'd have to read the actual data. I don't think I've ever actually looked at papers on this, but I can look at it. But I think the idea is that, again, we're talking about antioxidant, anti-inflammatory properties. Could they be beneficial in neurodegenerative conditions? And I think the answer is yes. Does that mean if you go stockpile and eat a bunch of honey, it's going to fix your condition? Probably not. But could it have some protective effects? Maybe. I don't know. Put it in your tea. Let's see how it goes. Um, and so that's kind of my thoughts on that. I will look into it a little bit more to see if I can find out what the actual data shows. I haven't seen any papers on it recently, but it is interesting in terms of honey, or basically a lot of bee things in general. So I'll give you more about that next time. I'll try to look it up for you and see what I can find. There are publications to help newly diagnosed Parkinson's patients. Why are they not accessible and abundant to doctors who predominantly deliver the diagnosis? I mean, they probably are readily available. We just don't, for us to use. I just don't know that we necessarily. Well, I won't generalize this. I'll tell you what I do in my office. I don't have handouts that I usually give to people. Usually, if somebody, I usually do get my nurse navigator on board, and she usually gives people a folder, with support groups and the foundations and things like that. I try to keep the information as compact and simple as possible because I do recognize that getting diagnosed with Parkinson's disease is a lot to process. Now, on the one hand, I would say that most people know why they're coming to my office. They know what I do, they know what I diagnose. And so it's very rarely that somebody comes to my office and I surprise them with a diagnosis. It happens. I mean, people don't always know why they come to my office, but most of the time I would suggest they have already know why they're coming to me, whoever sent them to me, what they were thinking. And so when I deliver the diagnosis or I talk about the diagnosis, it's not too big of a shocker. In fact, most people have already done their reading, been online, searched through things, and they come to me pretty knowledgeable. If they're not, I have no problems giving them more information or pointing them to resources like the local Parkinson's Foundation, Western Pennsylvania, the Michael J. Fox Foundation, the National Foundation. I mean, these are the Davis Phinney Foundation. I mean, these are good resources and websites. But I don't have a lot of papers or things like that that I give to people. I don't think that it necessarily, helps in the office when I'm delivering that information. It could be useful after the fact. So they get home the next day, the next week, they're processing this thing. It could be beneficial, and maybe I should change my ways, but I'm probably not going to. I've been doing this too long. And so that's probably why if you come to my office and I diagnose you with Parkinson's disease, I'm not going to give you a fistful of, here, read this publication on newly diagnosed Parkinsonism. Not to say that that's right. I don't necessarily do everything right, believe it or not. And maybe it would be beneficial, but that's probably why, it's not that I don't give people information or tell them where to go. I just don't hand them a lot of specific things. So that's probably why I do it. Now, again, I do give a folder with support groups, exercise classes, the local foundations, phone numbers, things like that. So I do give some information, but maybe not as much as you'd be looking for. That's just kind of my line of thinking. Other neurologists might do things differently. Other movement disorder specialists might do things differently. They may be more prompt to give people, papers or articles or more information than I do. I think a lot of it in to me is more of a communication, more of a conversation. I don't want to just be technical and give you a paper or an article. I want to talk about it. I'd like to say, look, this is why you were sent here. This is what I hear when you tell me your story. This is what I see that leads me to this diagnosis. This is what that diagnosis means, and these are the things we can do about it. That to me, I think is how I prefer to do it. And I think that's a better way than just giving you different things. But I guess everybody would have a little bit of kind of a different take on the best way to deliver the message or give the information. I have no idea if that actually answered the question, but I'm going to go with it. Um, what is the hype about methylene blue? So methylene blue's been talked about for a long time. I remember hearing about methylene blue. Geez, I want to say it was probably 6 or 7 years ago at the movement disorder conference that I went to in Vancouver. I don't remember when that was. Yeah, my brain, everything runs together. Could have been yesterday, could have been 10 years ago. But regardless, I feel like the talk about methylene blue has been around for a while. And again, similar to what I just mentioned before, it's thought that methylene blue as a supplement works on mitochondria. I don't know the mechanism of methylene blue. I'd have to look that up for you, or what the data actually suggests. I actually haven't seen any papers on this in a while, so I'm not sure if there's some new information out there in terms of hype about methylene blue, or this is still all based on the old stuff that we used to talk about. I feel like they did do small studies that were questionable or maybe showed a little bit of benefit, but I'd have to look it up for you again. But the idea is that theoretically it helps preserve mitochondria. And again, mitochondria are the powerhouse parts of the cells that theoretically are not working correctly that lead to the onset or progression of Parkinson's disease. When we talk about Parkinson's disease, we talk a lot about the mitochondria. We talk a lot about cellular function and mechanism. We talk a lot about degradation or byproducts and not being able to clear these byproducts. We talk a lot about inflammation and antioxidant properties. All of these things are thought to be part of the progression or development of Parkinson's disease. And so any supplement or medicine or thing that has antioxidant properties, mitochondrial protection properties, anti-inflammatory properties are going to be thought to potentially be beneficial in these types of conditions. And I think methylene blue, which was talked about for a little while, is in that category. I think it's theorized to help mitochondria function better or maybe stay alive longer to potentially slow down disease progression. I don't think it's ever been shown to do that yet. I'd have to go back and look and see where we're at in the studies on this stuff, but I think that's where the hype comes from. Again, I can't remember seeing any good studies on it that suggested it was beneficial, but again, I'll take a look into it for you. So going back to the electrical stimulation on the feet, and could that help with walking and balance? Could that interfere with DBS stimulation? That's a good question. I'm not sure. Again, we're talking about stimulation on opposite ends of the body. Would it be powerful enough that it would interfere, interact? I don't know. That would be a good question for the surgeons, or actually the DBS companies themselves. So let me make a mental note of that one and see if there's been any report on that. I don't at first glance, my first opinion would be no, it shouldn't be a big issue. that both would be far enough away, and the DBS is fairly protected in where it's located, that it should not interfere. But I'm going to ask the Boston Scientific or the Medtronic reps to see what they think, see if they've heard anything about that. And that's another thing I'll get back to you on. I will look at that, honey. I will look at honey when I look at that research. How do I decide it's time to have a patient begin medicine? That is a great question with a really long answer. So believe it or not, I actually don't like putting people on medicine. Everybody in here who's my patient is probably on a medicine and they're like, he's a liar. He that's all he does is give me more and more medicine, which is probably true. But believe it or not, I actually don't like putting people on medicine unless we have to. This is my opinion. So, and it's a really long opinion, so bear with me. I do not have a disease modifying medicine in Parkinson's disease. And so this is a really important topic and a really important thing to know. I can't fix it. I can't slow it down. I can't alter the course. When we think about disease modifying treatments, we think about medications or treatments that actually slow down disease progression or keep you better longer or alter the course. We have these in some conditions. We have these in MS. So we have disease modifying medications in MS. There's some in ALS now, although they're questionable or not tremendously disease modifying, but disease modifying. So we do have other neurological conditions where we have disease modifying treatments. We do not have those in Parkinson's disease. Why that's important is if I had a disease modifying medication, something that if you took it, you stayed better longer, it slowed down disease course, then two things are true. One, I would have to be very definitive in the diagnosis of Parkinson's disease, right? Because the sooner you diagnose somebody with Parkinson's disease, the sooner you would start treatment and the better they would do in the long run. So I would be pressed to be more quick and accurate in diagnosis of Parkinson's disease. And then secondly, along with that is you would have to take medicine right away. The idea behind disease modification is that the earlier you start it, the longer you do better. And so if I diagnose somebody with MS, which I don't do because I don't take care of multiple sclerosis, but if I did, I would want to put them on medicine right away because the sooner you put them on medicine, the less relapses they have and the better their overall course is. And so the earlier you start a disease modifying medication, the better you do long term. Now, since I do not have any disease modifying medications, one, I don't have to be as quick or as accurate to diagnose somebody with Parkinson's disease. I can start with the diagnosis of Parkinsonism, wait and see how it progresses, wait and see how the response to medicine is before I say, okay, yes, I do indeed think this is typical Parkinson's disease, or no, I think this is atypical or one of the other Parkinson's like conditions. And I also don't have to be in a rush to put people on medicine because there's no disease modification. Theoretically, and I say theoretically for a reason, there's no risk to waiting to take a medication. Now, that only applies when, disability is not involved, right? It doesn't make sense for somebody to hold off on taking medication to then continue to get worse and fall and end up in the hospital. Okay, we missed an opportunity to actually help you do better. So theoretically, you don't have to be in a rush to put people on medicine, but you also don't want to wait forever because you are missing an opportunity to impact quality of life. Okay. Since again, I don't have a disease modifying medicine, I don't have to be in a rush to put people on medication. It's not like the earlier you're on it, the better you do. Because of that fact, the only time I have to put people on medicine is when you, and I'm pointing to all of you, or you in general, or you, the patient, tell me that I have to put you on medicine. And I do that by really trying to get into quality of life. All of the medicines that I have are symptom management. And so all the things that I do in my office all day, every day is trying to impact quality of life in a good way. My goal is not to fix you. It's not to cure you. It's not to slow this down or keep you better longer. Only you guys can do that with, my favorite topic. I'm going to mention it in a minute. My goal is to help your symptoms so that your quality of life is better and you can get back to doing the things you like to do. That's the name of the game in my office. And so the way that I go about that is I ask you, I say, okay, what is the thing that bothers you the most? Because realistically, if I'm going to put you on a medicine, I want to make sure we're targeting the thing that bothers you the most. So pick whatever symptom bothers you the most, is most irritating, most bothersome, is most impactful of your quality of life. And then the follow-up question is how much does it bother you? Does it bother you to take enough to take a medication for it? Because when we think about medicines, every time I give out a medicine, there's a risk benefit. There is no such thing as a side effect free medicine. That just doesn't exist. Every single medication known to man has side effects or potential side effects. And so when you're thinking about this risk benefit profile or ratio, you want the potential benefits to outweigh the potential risks. We know the potential risks. The potential risks are side effects. I know the side effects. I know relatively what the chances of getting those side effects are. If your symptoms aren't bothering you, they're not keeping you from doing things, they're not impacting your day to day life, how much benefit am I going to get? I'm going to give you a medicine, but if you're already doing all the stuff you want to do and it's not keeping you, it's not disabling you in any way, shape, or form, that potential benefit really isn't all that much. And so the potential risks outweigh the potential benefit. Now, let's say your symptoms are keeping you from doing things. I can't go fishing or I can't go golfing or I can't, run or jog or swim or do the things I want to do. Or, I don't like to go out to eat with my friends anymore because they point out my shaking or they notice it and I'm been embarrassed. If your symptoms are keeping you from doing things, okay, now my potential benefit is significant, right? I have the potential of allowing you to do the things that you couldn't do or aren't doing because of your symptoms. And so now the benefits maybe do outweigh the risks. That's how I make these decisions in my head. And I get that information by really asking you what bothers you the most and how much does it bother you? How much is it impacting your day-to-day life? How much is it really keeping you from doing? That's really how I come to the conclusion or decision to put people on medication. I'm not eager to put people on and those exact questions are exactly how I decide every time you come to my office. Do we need to increase your medicine? Do I need to add another medicine? Again, I'm not going to do that just for funsies. At the end of it, there's going to be a good reason that we want to give you more medicine. And it's because something is either impacting your day to day life or quality of life, or really bothersome enough that we need to attack it. And the potential risks are outweighed by the benefits. And so that's how I do it. Again, I'm not sure how your neurologist would do it or other people do it. Those are the questions that I ask all of my patients pretty much every time they come to my office when we're deciding, what we want to do. Um, and that's how I come to the conclusion about whether or not you need medicine. I'm not in a rush to put you on medicine. I would prefer not to put you on medicine. You are much less likely to call my office complaining about a side effect if I don't put you on any medicine. Believe me, I'm aware of that. And so I really try not to get, I don't give out medication lightly. There really is a time and a place and a reason behind starting medicine. There really has to be a goal, but that's how I go about doing it. Welcome to my brain. Speaking of what is disease modifying, and my favorite topic for everything, for every talk, for every patient, does exercise help patients with normal pressure hydrocephalus? I don't know the data behind MPH in terms of its benefit from exercise, but I'm going to answer that question with yes anyway. I actually don't know if that's fact. I might be making that up, but I really do think exercise is the best medicine for every medical condition known to man. And so realistically, I have to assume there is some benefit even in non-Parkinson's conditions like normal pressure hydrocephalus or even the Parkinson's plus conditions or even the dementia conditions or every other condition known to man. I really do think getting up, being active and exercise is the best way to help everything. And I say this not based on necessarily studies. I say this on 10 or 11 years of taking care of patients. I can tell you time and time again the patients that come to my office that do the best are the one that exercise the most. You can tell when somebody comes to my office that they have been somebody who's gone to the gym their whole life, that they have exercised their whole life because they look great. They do great. They're the easiest patients to take care of because A, I don't have to yell at them about exercise, but B, because they do better. I don't have to give them a lot of as much medicine. I don't have to escalate medicine as quickly. The second group who do the best are the ones that after I yell at them once or twice or 10 times, they actually take my word for it and eventually adopt a very exercise heavy lifestyle. They start going to the gym. They really put forth the effort for exercise and they really spend a lot of time focused on exercise and physical activity. They do the next best. And the patients that do the worst are the ones that, for whatever reason, either because they can't be motivated to do it or physically they just can't do it. They have heart problems, they have knee and back problems, or whatever. No matter how many times we talk about it, I can't get them to really buy in or do a lot of exercise. They do the worst every time. And again, that's just been my experience. I don't think it's just my experience, but that has been my experience. And this is why I spend so much time talking about exercise, because hands down, it is definitively the best medicine for everything. And so I assume it's also a good medicine for normal pressure hydrocephalus, which is a different condition, but has similar features in terms of walking and balance and things like that. I can't say that with any fact. I may be making that up. It's quite possible, but I'm sticking with it. Once on medicine, can you stop it? Yes. Now, the caveat is why are you stopping it? So I stop medicines a lot of times. Um, Oftentimes it's really to see what they're doing. But the short answer is yes, we can do whatever we want. If I put somebody on a medication and they don't think it helps or it has a side effect or it has a problem, even if it's carbidopa levodopa, I can have no problem stopping it. Probably where you'll see this the most is when kind of early in the diagnosis or course of disease, especially in something that's a little bit atypical. So if somebody comes to me and they look like they have Parkinson's disease and I put them on carbidopa levodopa, and then they call me up in a few weeks, they say, you know what, I'm not really sure it helped. And I say, "Oh, that's okay. Let's try a little bit more. Some people need a little bit more." And so we ramp it up a little bit. And they're like, you know what, I'm still not sure it's really helping me all that much. Let's try a little bit more. Or however high we go. It's very subjective in terms of how you do this. Eventually we get to the point where we say, you know what, is it really helping you? Or they'll say, well, I think it's helping, but I also am very dizzy and I'm not sure if that's the medicine or if that's the disease, or I'm having this problem. And we're like, well, I don't know if that's the medication. Is that the disease? Is that something else? These are all times where I'll talk to the patient and I'll say, you know what? Let's take you off of it. That's the best way to find out if it's helping, if it's hurting, if it's causing a side effect, if it's causing a problem, if it's doing more than we think. And not that I ever want my patients to just stop medicine like that. That's usually a terrible idea. Wouldn't recommend that. But oftentimes I will say, okay, let's back it back down. Let's taper it off. Sometimes we taper it off and we say, wow, that was really helping more than I thought it was. Sometimes we taper it off and it wasn't doing anything. In fact, it was only causing side effects, in which case I'm like, okay, we need to switch to something different. And so the short answer to the question is yes, you can indeed stop the medicine. However, a lot of times the medicine really is helping or giving you more benefit even than you might think it is, especially when you've been on it for a really long time. You've been dealing with it for a while, and it's human nature, and myself included, to forget what it was when we first tried a medicine or did something. And so it often gets to the point where we say, well, we're not sure if it's doing anything any good anymore, and we'll stop it and see what happens. So there are instances where I will stop people's medicines or taper them off of one or more or all of their medicines to see what it's doing. And so that's just a very long answer that says yes, once you're on a medicine, you can indeed stop it. It's just a matter of what are we trying to solve, what are we trying to accomplish, and what do we do next? Yep. Is mental confusion a symptom of Parkinson's? Inability to make sense of 2 to 3 written or oral sentences. So if you've ever heard me give any of these talks before, you know that as soon as you say is dot 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 a symptom of Parkinson's, the answer is always yes. Parkinson's can literally do anything you can think of. Every single condition, symptom, every single body system is impacted in Parkinson's disease, top to bottom, left to right. And so literally, if you come up with a symptom, I can find a way to correlate it, or it more likely is related to Parkinson's disease. And mental confusion is no different. So I hear a lot of variations on this topic. So, it ranges from everything to just a slow thinking to just kind of confusion or cognitive decline, where ultimately could be lead to mild cognitive impairment or full-blown dementia, or it's basically a spectrum of all the things that can happen from a cognitive or mental status standpoint. I would argue that kind of brain fog, mental fatigue, slowness of thinking are probably what I hear most commonly. But it can be just, processing speed is slow. So I give you multiple commands and you can only do the first one. A lot of significant others say multitasking is out the door. Don't even try. I will give him lists of one thing and then another and then another and then another. I cannot give them more than one thing to think about at a time, or none of them happen. These are all very common things that I hear in the office. And so, yes, I do think mental confusion, brain fog, brain slowing, slowed processing, all the way up to and including mild cognitive impairment, which starts becoming more significant, and dementia, which is where day to day life is impacted, are all potentially part of Parkinson's disease. What we do about them varies from patient to patient, trying to figure out, is this something just that's slow and maybe you're physically slow and that goes along with it. And maybe a little bit more dopamine medicine can speed things up and that would help. Two, do we need to start thinking about the dementia medicines or the Alzheimer's disease medicines, which I use a lot in my patients, not just for cognitive issues, but for walking in balance? Um, I believe it was on here where I learned about speed of processing brain games, which actually have some evidence to help cognition in patients with Parkinson's disease. I believe that's the Brain HQ. And so there are some things we can talk about, try to tease out the underlying cause or culprit, and really figure out what do we need to do about it. And again, it's another thing that you should not sit on. It's another thing that you should bring up and talk about with your neurologist or your movement disorder specialist or your doctor. Make sure they understand the situation, particularly, and this is also similar to every other symptom you can think of. If you're coming to me, I'm going to want to know, is this constant? Is this fluctuate? Is there any association with when you take your pills or medications? Can you can you pick up or notice a pattern to this? Because all of the answer to those questions are going to help me figure out what to do about it, or what can we adjust, or what kind of things can we think about. And so starting to think about those things also might help when you're talking to your neurologist or your provider. But the short answer is yes, mental confusion and the whole gamut or array of cognitive issues can definitively be part of Parkinson's disease. Casey, I ended right on time, and that was
Yes.
the last question in the box. So
Hey, thank you so much,
success.
Dr. Licklider, and everyone for joining. We have one more talk with the doc for this year on December 4th. And stay tuned for upcoming programs. Check your emails, and we hope to see you again soon. Thanks, everybody. Goodbye. Good night.
Bye, guys.